Okay, hello everybody. Great to be back. Great to see a lot of familiar faces from last year. With that said, you may be thinking, or some of you may be thinking, didn't he talk about this last year? Yes, I did. And I'm going to keep talking about it until we have some progress. Unfortunately, things are moving slowly in the direction that they need to be moving, though just as a little bit of background, in Tanzania, where I'm primarily located, we have seen some shifts, some ideas of maybe increasing services for these kids with low-level viremia outside of our clinic, of course, which we do a lot more. These kids are being enrolled into our Viremia clinic, so that's part of kind of the Viremia clinic that we have in Mbeya in Tanzania. But let's get back to this. So if you'll indulge me for a bit, I will talk a little bit about the background or why I chose this topic, but maybe also background to that, this idea of working with these kids with viremia is something that hopefully we'll be able to expand, and we're, as you know, with Baylor College of Medicine and our global network, we have a lot of sites that are involved with children with viremia. So it's something that maybe we'll be able to expand and continue to expand and hopefully get better data. So just a quick maybe imagery of why this is an important topic. This is something that I started in Mbeya about 8 years ago now, and it was something that struck me almost right off the bat, that this idea of low-level viremia or failure, identifying failure at a level of 1,000 copies per milliliter was striking to me. And so when we're talking about success here, right, so we've heard about the 95 goals. So that's a success that we're all aiming for. And the road that's going to take us there, things that we all strive for in children, and it's something that people who are caring for children, who are involved with the care of children, we use these ideas or ideals such as equity, cost effectiveness, evidence-based, using evidence-based even in places like Sub-Saharan Africa. Child advocacy, of course, is top for us. But there's some things that some kind of ideas or methods of practice that may take us off the road to success. And so we have things like settling solutions, so like thinking of, okay, it's good enough in this setting. Okay, we have things like short-sightedness. Okay, we're only looking for this year, 2025 or 2030, instead of looking like beyond, like what, these children are going to become adults, like what's going to happen to them then. Post hoc explanation, so okay, after the fact, oh well, that was okay, that worked, so let's just continue to do that because that's what we've always done, even though the evidence doesn't show that that's correct. And so my advocacy work is going to try to keep us along this road and hopefully get us to 95%, but not in a way that will set these children up for having problems in the future. So, low-level viremia. So I think we've all had lunch, so this shouldn't be too enticing to people, but we have a donut. And the donut hole is where this sits. And any of you who is involved with work with children or even adults in Sub-Saharan Africa, you see that the first part of the donut is the children who are suppressed. So the suppressed kids, they get different services, they get multi-month prescribing, they're told that they're doing well, and so their services are good. Then we have a gap, right? So 50, many times it's 50 to 1,000. and nothing happens, okay? Nothing happens. Oftentimes those children are continue along. Maybe they're told they're doing well, even though they're viremic, basically, by definition. And then the second half of the donut is once they reach 1,000, and then they get a lot of services, like we were talking about, adherence counseling and so on. And so I'm focusing on that hole and hopefully to close it, because in a lot of places in the world where HIV care is given, there is no hole there, okay? So just as it's kind of a look at the literature. So the literature is increasing in this topic, but it's unfortunately is still very, very low amount for children, and so mostly in adults. And we see that the risk of virologic failure, we can see the hazard ratios there on the right, oftentimes above 2. And unfortunately, in the literature, there's a variety of definitions due to the fact that different ways of doing viral load testing. Different machines have different definitions of suppressed, but for the work that I've been doing, my definition will be 50 to 1,000, and you'll see that what we came up with when we looked at these children in Tanzania. Okay, so what I did was a retrospective chart review looking at data from 2004 to 2022. These are our 2 sites in Tanzania, Mbeya and Mwanza, and looking at children aged 0 to 19 on therapy for at least 6 months with at least 1 viral load that's less than 50, so what would be considered suppressed, just to try to eliminate as much bias as we could, and then looking at the 2 subsequent viral loads after that one. So this, you can see the sort of the path. So we're looking at the 2,618 that were included in this outcome analysis. And the median age was about 13.2, half were female. Most were on dolutegravir-based regimens, and this is something that you saw when Katie was talking about Malawi. We basically followed along on the same path. 2019, we got the dolutegravir 50 milligrams, and then 2022, we started for children with the dispersible tablets of the 10 milligrams. Low-level viremia was found in about 40% of this population. Okay, and I'll quickly go through these, basically to say that, as you see, there was between the low-level viremia and the no low-level viremia. So the ones with low-level viremia were significantly older, and so you can see that both in age and age group was statistically significant. The ART start was not different, nor was sex between the 2 groups. Number of viral loads was about the same. It's about 1 per year. Again, this is a challenge that we have working in the developing world, is we just don't get that many viral loads. And so this was, I think, was a good data set because we were able to look at a very protracted time frame. But again, it would be nicer to be able to follow these children closer, but we're dealing with about 1 per year. And interestingly, the sites turned out to be statistically significantly different in the amount of low-level viremia. Why this is difficult to say, but we apparently have a lot more low-level viremia in Mbeya than they do in Mwanza. Something to look for in the future why this is. WHO stages were significantly different between the two groups, both at baseline and then current. The weight, as I said, CD4 counts were different, but probably not clinically significantly different. And then you can see that the categories of CD4 counts were not different. Time from ART to the first viral load was about the same, small amount of difference. And the years from ART to the very last viral load, probably this was a factor of the children being older with low-level viremia than the other ones. Tuberculosis was not actually found to be different between the 2 groups. And I talked about the ART regimens. Dolutegravir is very common, and you can see that there was higher amount of the two first-line regimens in Tanzania, TLD and ABC3TC dolutegravir there at the top. There was a difference between first-line and second-line between the two groups. But overall, looking at dolutegravir between the two low-level viremia and not, it was not statistically significantly different between the two groups. Okay, so looking at the results, when we define viral failure as greater than 1,000, okay, then you can see the hazard ratio of any low-level viremia. We can see a hazard ratio of 1.63 for virologic failure. And then you can see that when we stratified it by 50 to 199, 200 to 400, 400 to 999, the hazard ratios increased. And you can see that on this graph here. And then this one with stratified as well. So the green being the lowest being suppressed, and then up from there. When we define virologic failure as greater than 200, then you can see a hazard ratio is quite dramatic, and we can see the 3.85 for all low-level viremia, and then but you can see that from 200 to 200 to 399 and 400 to 999, it was 8 and above hazard ratio for failure, and you can see the separation there, and then. Interestingly, you can see that there was a large separation when once you hit over 200, that the graphs separate quite dramatically there. So, in conclusion, we can say that low-level viremia in children with HIV is associated with increased virologic failure. Higher levels of low-level viremia corresponds to greater risk. So. Just as a plug, my other poster here, looking at sort of an actionable clinical kind of more significant strategy is here. So I would recommend take a look at that online. Thanks to Baylor College of Medicine, Texas Children's Global Health, Baylor College of Medicine Children's Foundation in Tanzania, and Duke helped me a lot with the analysis. So thanks to them.